So there's a variety of biomarkers, of course, in modern oncology, and not just in GI oncology. So what a biomarker is, it's a characteristic of the disease, of the tumor, that we can test. Typically, we require tissue to do this. Sometimes we can discern it through blood samples. But it's something about that tumor, almost like its fingerprint, that makes it different in that person than if that cancer was occurring in somebody else. And so biomarkers, again, are allowing us to determine what is different about this specific person's tumor that might render them a candidate for a new treatment strategy. We also know that cancer evolves. The treatment you're giving today might change, and the biomarkers you're targeting might change. So testing biomarkers is not a fixed point in time. It is an ongoing opportunity when you're reevaluating the patient to not just look at labs and scans, but to actually retest biomarkers. And that requires a dialogue with your pathologist. They are the unseen heroes of modern oncology because almost every oncologist needs to have a relationship with a pathologist who can test for these biomarkers. And what they do in the lab affects what we do in the clinic. The HER2 biomarker is present in other cancers besides breast and gastric. We see it, for instance, in the biliary tract. It can be seen in the colon. It can also be seen in the lung. PD-L1 expression is seen in a variety of tumors. It is certainly seen in lung cancer. It's also seen in gastric, stomach, and esophageal cancer. So MSI, or microsatellite instability, is a hallmark of many cancers, but most often is seen in the GI tract in the colon. Up to about 20% of colon cancers will be what we call MSI high, and those patients then are candidates for a different treatment strategy altogether that might not even require chemo. Claudin 18.2 and FGFR2b are important emerging biomarkers in gastric cancer. So Claudin 18.2 can now be present in a manner that we can see by biomarker testing and that we can target. So an antibody can come and attach to the Claudin 18.2, and that can lead to the death, potentially, of the cancer cell. FGFR2b can be overexpressed, and that's a signal that the cancer itself is becoming overactive through that receptor, and that also renders it potentially targetable to a refined treatment strategy. Biomarkers, both in gastric cancer and in other malignancies, will allow the understanding that each cancer is different and that our treatment should be targeted towards those differences. It's also important to realize that testing the patient over time reveals the changing landscape of any given person's cancer. And I think it's that dynamic understanding, I think that's where we're heading. I think it's really important that we don't treat everybody the same, and also that we don't treat the same person the same way at the beginning of their treatment as we might in later treatment decision points. My patients with gastric cancer are amazing because when they come to me, many of them are aware that historically this is a disease that has been incredibly serious and often lethal. And yet they come to me with a tremendous amount of hope. And they do not allow the past to determine their present or their future. And they are also remarkably willing to think about new treatment strategies, sometimes in the context of clinical trials. I'm really excited about emerging biomarkers in gastric cancer like Claudin 18.2. This is not something we have traditionally been testing for, and that means it's an opportunity to improve the care of these patients.